Okay, so Dr. Zakara is going to be presenting on the comparative assessment of FLACS in MICS in senile mature cataracts.
Good afternoon all. Let's discuss about the comparative assessment of femtolaser assisted cataract surgery and minimal invasive cataract surgery in senile mature cataract. Nowadays, people are coming to the cataract OPD thinking like they will get best vision after the cataract surgery irrespective of the patient age or the grade of the cataract. So the surgical precision, accuracy and the post-operative comfort is the need of the hour. Irrespective of like whatever the surgery is, whether it is an MICR or FLACS, mature cataract has various surgical challenges. This novel study focuses on the mature cataract and its set of unique challenges. And our aim is to assess and compare the effectiveness of FLACS and MICS in evaluating intraoperative performance and the postoperative outcomes in senile mature cataract. And we compared vision, IOP, corneal parameters, both pre-op and post-op, and also the intraoperative parameters. And it was a prospective comparative observational study conducted over 15 to 18 months over a group of 72 people, 36 in each group, and operated by a single surgeon. And we included all the well-dilated pupil with mature cataract and aged more than 50 years with clear cornea and no other ocular pathologies and no history of previous ocular surgeries. And we calculated central corneal thickness, endothelial cell density, coefficient of variation, and endothelial hexagonality with the help of specular microscopy, both preoperatively and postoperatively. And intraoperatively, we evaluated the cumulative dissipated energy, total surgical time taken for the procedure, amount of balanced salt solution used in both FLACS and MICS procedures, and how the circularity is made in FLACS and MICS, and whether there is any intraocular complications happening during the procedures. And the intraoperative results, when we compare, there is a significant difference between the FLACS and MICS when we are comparing the circularity of the rexus. There is circular central rexus in FLACS 88.9%, which is more when compared to the MICS. But the number of capsular tags which are seen in the FLACS are more when compared to MICS. Same like CD, cumulative dissipated energy, time, and balanced salt solution used in FLACS are lesser when compared to the MICS. And there is a significant difference in the percentage change of the central corneal thickness from day 1 to the day 30th, which includes the value in day 7. We calculated the values with the help of Pentacam. And a significant change was there in MICS group where the central corneal thickness was more post-op 1 month when compared to the FLACS. Similarly, percentage change of coefficient of variation and percentage change of endothelial cell density shows significant difference between the FLACS and MICS, where FLACS shows a better result. And these are some other studies which show similar results like us, whether preoperative and postoperative pacmetry shows MICS have a more central corneal thickness post-op 1 month when compared to the LensX group, and post-op endothelial cell density value post-op 1 month showing better endothelial preservation in LensX groups. Now we know that intraoperatively with the help of laser, we can able to make a central circular proper size rexus. Even the number of capsular tags are more. With the proper size rexus, the position of the lens, we can able to keep it properly, which help in the effective lens position, and later on helps in the vision of the patient. And also we are using grid pattern of the laser, which will help in the removal of the cataractous lens later on, which will reduce the cumulative dissipated energy, which we are using intraoperatively. That itself will reduce the operating time and the amount of fluid used intraoperatively. And all these factors which help in the better endothelial cell preservation in the postoperative period. And the percentage change of the central corneal thickness was significant in both groups, where MICS shows more increase in value of the central corneal thickness postoperative 1 month. And whatever the central corneal changes or the intraoperative parameters post-op 1 month, patient was like vision-wise, IOP-wise, corneal clarity, anterior chamber inflammation, from every aspect, patient was like similar in both MICS and FLACS group. And like limitations, I didn't assess the effective lens position and couldn't able to compare the keratometric changes because we are not putting the incision with laser, and sample size and follow-up was less. And FLACS has a superior edge of the superior edge over the MICS over superior circularity of the capsulotomy, lower cumulative dissipated energy, shorter surgical time, less fluid used intraoperatively, and better endothelial cell protection postoperatively, makes it the surgical efficiency of the FLACS is better as compared to MICS in senile mature cataract. Thank you.
So, according to you, which all were the shortcomings in your study? What were the shortcomings in this study of yours? You did tabulate few of them.
Which was the shortcoming in your study?
Like
one shortcoming that you think?
Negatives.
Yeah, negatives.
Okay. In the study, in FLACS groups. Like limitations mainly, ma'am, actually if the incision was there, post-operative astigmatism, how it is. When we are making the corneal incision with manually and with the lens, whether it is affecting the post-operative astigmatism, we could have assessed properly if the incision comparison we had done. Then the another one is we only refer the patient for follow up the patient for 1 month. So in that 1 month period, the corneal thickness and the endothelial cell count, we couldn't able to assess properly. If it was a minimum 6 month study, I should have assessed it more properly, and the effective lens position other ones, because the central circular proper rexes we can able to make with the laser procedures. So because of that, if manually, whether we can chance that we can make a bigger rexes or a smaller rexes, which can cause a hyperopic shift and myopic shift later on in the post-operative period. Here actually in the laser it should be a proper central rexes which help in the effective lens position. That I couldn't able to assess because I couldn't able to check the effective lens position in my study.
All right, thank you.
Thank you.
Thank you.